as we get more and more experience with MR, trying to put it in a slot, figure out where it is of use in terms of heart disease. In terms of acquired heart disease, especially coronary artery disease, I'm not convinced that we have much to offer at present that can't be done by other, perhaps cheaper and simpler techniques. However, there's absolutely no question that in terms of tumors of the heart, MR is, I think, the best diagnostic method we have. Now, tumors of the heart it's very good for because we get a tremendous contrast in this a spin echo image where you have the blood is black and the soft tissue mass stands out very starkly against it, or in gradient echoes where smoothly flowing blood is white. You will now see the mass as a less of a signal intensity, but still very sharply outlined. These, of course, are the same patients. So MR is extremely good for showing you lesions within the heart without contrast. The necessary contrast is there from the start. In terms of primary cardiac tumors, about 3/4 of all primary cardiac tumors are myxomas. Myxomas are benign lesions. However, they are friable, and frequently pieces break off and can embolize. They don't grow or metastasize, but they do produce emboli. And also they can interfere with the working of the heart. Of myxomas, most of them arise, 3/4 of them will arise in the left atrium. They tend to be pedunculated. They tend to be attached to the interatrial septum, and they usually are mobile, so they flip-flop from the atrium to the ventricle as the heart beats, and they go back and forth. They can produce mitral insufficiency. They can produce a picture that's indistinguishable from mitral stenosis. Now, the diagnosis, and in the right side of the heart, the tumors tend to be more sessile. Usually the myxomata in the right atrium are broad-based. They are not as mobile. On the other hand, yes, occasionally there are pedunculated myxomata in the right atrium that prolapse through the tricuspid valve. The diagnosis of left atrial myxoma can usually be made quite accurately by echocardiography. This is an echocardiogram. You're looking at a 4-chambered view. Here's left ventricle, left atrium. This is interventricular septum into atrial septum. Here is a myxoma, a big mass, posterior to the mitral valve. This is during ventricular systole, the mitral valve is closed. The tumor is in the left atrium, and then as the left atrium contracts, the tumor now prolapses forward into the left ventricle. Here is the same patient on MR. It's a prettier picture, but really there's not any real indication for doing this study. This was done done for interest more than anything else. The echocardiogram is more than adequate for the diagnosis. However, if you have any question on the echocardiogram, or if there are peculiar findings on the echocardiogram, MR is invaluable. This patient had a large left atrial myxoma. It was prolapsing through the mitral valve. This is the same case I showed you previously. And by echo, they felt it was attached to the posterior leaflet of the mitral valve, and the patient was scheduled for resection of the atrial myxoma and replacement of the mitral valve. However, this is just a single frame from a movie. You can see, I think, the mitral valve is anterior to the lesion here. The tumor itself is actually fixed to the inferior wall of the left atrium, and at surgery, our findings were confirmed, and the lesion was removed without touching the mitral valve. Now, there is nothing about the appearance of a myxoma on MR that tells you it is a myxoma. In other words, if I cut out the lesion and hand it to you, there's nothing in the T1 or T2 values or anything you want that will tell you that it is a myxoma. We make the diagnosis because it is a smooth, lobulated lesion, most commonly in the left atrium. About 20% are in the right atrium. The other 5% occur in the ventricles. In the ventricles, we cannot make a specific diagnosis of myxoma. In the atrium, especially if it's mobile, we call it a myxoma. However, look at this patient. This is, again, a 4-channel view. Here's right ventricle, left ventricle, interventricular septum. And here is a mass in the right atrium during ventricular systole, and it prolapses into the right ventricle during diastole. I can't tell you that this is not a myxoma, but here you have to have some kind of clinical information about the patient. This was a drug addict. 8 weeks before this time, at an examination, had a normal echocardiogram. This time has a mass on the tricuspid valve, and had a fever. This is bacterial endocarditis with a vegetation, and the patient was treated with antibiotics, and after a suitable period of time, this lesion disappeared. But I cannot distinguish this from a myxoma unless I have this clinical history. One other thing to be careful of in reading these films, if you use gradient echo techniques, which is what gives you the white blood, the blood that is flowing smoothly appears white. Turbulent blood appears black. Turbulent blood causes a dephasing of the spins, and therefore you get a dropout of signal. Here is the right ventricle, and here, as the ventricle contracts, you see this black area going back into the right atrium. Now, could this be a mass? Well, the answer is no, and it's the same thing with contrast angiography, because look at a later phase in the cardiac cycle. It's beginning to diffuse. A mass is there throughout the cardiac cycle. This is essentially the same as a dilution defect on a normal angiocardiogram or a contrast angiocardiogram, and it's going to diffuse with time. Look at this case, which is it's a complex compound oblique view. This is a left atrial myxoma, and this is mitral insufficiency at the corner of the valve during ventricular systole. But then during ventricular diastole, you don't see the insufficiency anymore, so this is evanescent, but the shadow of the tumor remains the same throughout the cardiac cycle. So in order to diagnose a soft tissue tumor, it has to be a persistent defect on your films. A lipomatous hypertrophy of the atrial septum is, nobody's sure whether this is really a tumor. Some people think it's a hamartoma. It's a peculiar lesion. The importance to us as radiologists is that it's often misdiagnosed by echocardiography. This is from an echocardiographic article. I put it upside down so that it will conform in orientation to an MR image. This is a peculiar lesion that occurs in elderly people, especially obese people. It's an abnormal collection of normal fat cells and fetal fat cells in the interatrial septum. It is associated in some cases with atrial arrhythmias, although nothing particularly is done about it. The important point is that by echocardiography, they not uncommonly report a tumor in the heart. Well, the characteristics of this, it's fat, so you get a very high signal content, high signal density of the lesion, and it involves the posterior part of the atrial septum primarily, but it can involve the entire atrial septum with sparing of the fossa ovalis, as you see over here. And this is pathognomonic. There's no other lesion that will quite give you this appearance, and this is lipomatous hypertrophy of the interatrial septum. Actually, you can make the diagnosis, at least in this case we could, from the CT, non-gated CT, because here's the spine, it's a close-up of the heart, and you have this fat lucency in the region of the posterior portion of the atrial septum. This is the same patient, CT and MR. And this simply in the frontal and lateral view shows you where the posterior part of the atrial septum is. The atrial septum starts off on the right and posteriorly, and then courses anteriorly and to the left. Now, other tumors other than a myxoma that occur in the heart can be of any cell type, as tumors arising from connective tissue or striated muscle. This was a young child who had some limitation of his activity, was admitted for study. This is a right ventricular angiocardiogram with marked narrowing of the infundibulum. This is right ventricle, pulmonary artery, and there's marked narrowing of the infundibulum. You can see this mass of soft tissue encroaching on the infundibulum in the lateral view. And the diagnosis was made of infundibular stenosis. The child was scheduled for an infundibulectomy. However, since infundibular stenosis so often is a reactive stenosis secondary to a ventricular septal defect, a left ventriculogram was also done. This is a left anterior oblique view. And when this was presented preoperatively, I noticed this peculiar collection of vessels in the region of the interventricular septum, even more striking over here. I've never seen neovasculature or tumor vessels in hypertrophied muscle. You just don't see that. And on the basis of this, we requested that they send the kid over and let us do an MR examination. And here is the cross-sectional view of the left ventricle, right ventricle, and a big tumor in the interventricular septum. Now, I cannot tell whether this is a benign or malignant tumor, nor can I tell where the tumor begins and where it ends. Here is the lateral view showing involvement of the septum, but also involvement of the free wall of the right ventricle, giving you the infundibular narrowing. After we did the MR, of course, Echocardiography was done and showed essentially the same thing in the septum, although they could not evaluate the marked narrowing of the outflow tract. This is in cross-section that we could with MR. Their child was operated. The surgeon removed some of, he claimed he debulked the tumor. It was a benign capillary hemangioma. Now, unfortunately, this was done 3 years ago, at which time a lot of the clinicians still didn't take MR seriously, and the child was never sent back to us for a post-operative study. Parents moved out of town and just came back a week ago. We restudied the child. This is 3 years after surgery. Here's the tumor in the interventricular septum, the tumor in the outflow tract of the right ventricle. I have no idea what the picture was post-operatively. If I had a post-operative study, I could tell. I suspect that he did not take much tumor out, and this probably is a slow-growing tumor, if it's growing at all, but I can't prove it without that study. MR is extremely useful in following up kids. Now, another little child with a big mass in the left ventricle. I can't tell you, if you play the odds, it's going to be either rhabdomyoma or rhabdomyosarcoma. This was a rhabdomyosarcoma. I have no way of telling that from the MR image. This is a gal, 49 years old, with paroxysmal hypertension. And she was literally studied from nose to toes. She had all the chemical evidence of a pheochromocytoma. CT, MR of the abdomen was negative. Angiography all over the place was negative. She was treated symptomatically, came back 8 months after her original visit, and at that time had a mass on the chest film to the right of the heart, or at least fusing with the right atrial contour. Echo showed a lesion. Again, this is a four-chambered view where this is the right ventricle, right atrium, and there is a lesion in the wall here. They couldn't tell any more than that, just that there was an abnormality. MR examination, well, this is CT, and a dynamic CT with contrast in the heart did show a mass adjacent to the right atrium, but MR shows very nicely this large mass inside the pericardium. The black line is the pericardium, and the mass in the wall of the right atrium, which seems to be very sharply demarcated from the right ventricle. And here's another cut. You see this marked demarcation here, and here is the lesion in the frontal view. The patient was operated upon. When the surgeon touched the heart, the blood pressure shot up to way over 300. They had a heck of a time with her, and unfortunately this lesion was infiltrating the wall of the right ventricle and was felt to be non-resectable. We could not tell from MR. It certainly looks very sharply circumscribed on MR, not true at the time of surgery. This, well, obviously was a pheochromocytoma of the heart, or a chemodectoma. Secondary tumors of the heart, metastatic tumors, in about 10% of all patients dying of neoplasm, there will be some involvement of the heart or pericardium. The most common lesions to involve the heart, melanoma, leukemia, lymphomas very commonly involve the heart. But there are really two different types of secondary tumors. First of all, this is a patient with melanoma, big irregular mass in the atrial septum, and then a cut higher up. You see there's diffuse involvement of the walls of the heart. MR is far superior to echocardiography, because with MR you get a global view of the heart and the chest, and you can see it from any angle you want. Echocardiography is limited to the acoustical windows. For example, here is an echocardiogram in a long axis view. This is left atrium, mitral valve, left ventricle, and aorta. And you can see this mass of soft tissue in the posterior wall of left atrium and left ventricle. Here is the MR, again with the tumor here extending around the left ventricle. But in addition, we can now do films of the chest in the coronal view. You see not only is there involvement of the base of the atrium and ventricle, there is mediastinal involvement. Here is probably a pseudotumor in the short fissure on the right side. And you can get a much, much better idea of the extent of the tumor with MR. Now, a different type of secondary tumor, which does not have the terrible prognosis, the previous case, obviously you have metastatic disease to the heart, the patient is inoperable and probably incurable. But here is a patient who had evidence of systemic venous hypertension, swelling of the legs, and on echocardiography they found a mass at the base of the right atrium. And here you can see a mass at the base of the right atrium, just where the inferior vena cava enters the atrium. Here's a cut a little bit lower with a tumor in the inferior vena cava. and it grows up the inferior vena cava from a hypernephroma in the left kidney. And the kidney was resected. The tongue of tumor extending up to the right atrium was not fixed to the inferior vena cava, and it was delivered together with the kidney at the time of surgery. So in these cases, it is not necessarily true that the patient is totally incurable. You may be able to get away with it. This was a patient with a carcinoma of the right lung, and on echocardiography was found to have a big mass in the left atrium, and that's exactly what we see here. This, and when the surgeon saw this MR, he just figured the patient was inoperable. Dr. Ziffert, our institution, who was a radiologist, saw the left atrial wall here, and he raised the possibility that this tumor is simply growing in through the pulmonary vein and may be resectable. At the time of surgery, this was totally free in the left atrium. There was some infiltration of the pulmonary vein near its orifice in the left atrium. The surgeon could do a wedge resection of the vein. The total mass was delivered with the tumor. Now, I'm not saying this is a cure, but this is 6 months later. The patient has no evidence of tumor in the chest. Lastly, there is, in terms of this, there is no such thing as a free lunch. This is a patient with a carcinoma in the right lower lobe who was suspected of having a mass in the left atrium by echocardiography. These films were sent in to us from a neighboring hospital who had, this is a state-of-the-art, it's a very good MR machine, a totally useless examination. Here is the same patient that we redid about 3 days later, and here is the carcinoma in the right lower lobe with an extension through the pulmonary vein into the heart, and on gradient echo movies you see the same thing. And this was not fixed to the pulmonary vein. It could be delivered together with the primary tumor. The difference between these two studies is how much time and effort you want to spend in getting your study. All these studies are done with cardiac gating. When you do cardiac gating, you're looking for some high point of the EKG that you can trigger your machine from. And if you do not get a good differential, if the R wave and the T wave, which in this patient were very much similar, then the machine triggers off the R wave sometime, off the T wave sometimes. You don't get gating, and you wind up with a conglomeration of shadows that are totally useless. We spent 20 minutes fooling around with the EKG leads on this patient, moving them around to all kind of places, and don't use the standard positions. You can't predict which way you're going to have to put them until we finally got the R wave significantly higher than the T wave, and that's the result once we got decent cardiac gating. Now, paracardiac tumors, the heart is in the anterior mediastinum, and paracardiac tumors are anterior mediastinal tumors. And the two most common that will overlie the right border of the heart is the dermoid, or as Dr. Gamson called it, benign teratoma. And notice in terms of what I'll show you this afternoon with the pericardial cysts, you can see a very sharply circumscribed posterior wall to the dermoid. And here is a thymoma. Both the dermoid and thymoma arise high up in the neck. Both of them can be pedunculated tumors, and both of them hang down. They occur most commonly on the right side, but they can be on either side, and they can hang down and reach the diaphragm, so that you should always consider this in term when you have a pericardiac lesion. Now, Hodgkin's disease, which can involve the superior mediastinum, usually does not involve the lateral portion of the heart because there's not much in the way of nodal tissue there, unless you have a patient such as this where the Hodgkin's disease is infiltrating the thymus. And then the thymus can hang down just like a thymoma, and I think you almost make out perhaps a sail sign at the base here. And this is right pericardiac mass circa 1991. This did not exist 4 or 5 years ago. This is a patient who had had multiple coronary bypass grafts. He had a terrible heart. He was in chronic congestive failure, couldn't get out of bed. He was in his 60s. They did not feel he was, they didn't want to do a cardiac transplant or a cardiac replacement. This is a piggyback heart. This is a second heart put in the chest, laying up along the right side of the heart. And you can make these diagnoses, if you have to study this by MR, you're going to spend an awful lot of time because the two hearts beat. The heart is denervated, so it beats at a different rhythm than this heart. And you have to, you can only get one heart at a time on an MR scan, and you have usually the second heart you can fool around. The EKG has to go somewhere posteriorly on the right side before you're going to pick up the second EKG and be able to get decent gated images. The diagnosis when you have a mass in the paracardiac region, either CT, this is a malignant teratoma, or MR, this is a thymoma with hemorrhage within it. It doesn't pay to fool around with other techniques. You just go where you can get the most information. Either MR or CT will suffice to diagnose these lesions. Now there's another group of conditions. They're masses in the heart or associated with the heart that are not neoplasms. And this is an example of a patient with a bulge on the right border of the heart. In the oblique view, you can see it's a rather localized thing. Now, a sinus of Valsalva aneurysm usually projects higher up. They can hang down, but this would be sort of peculiar with these sharp angles here. I've seen cases like this, 3 or 4 times. I've been shown them on panels when I'm giving them as an unknown, and in all honesty, I miss it every time because I don't think of it. But this is an example of a coronary artery abnormality. A coronary artery aneurysm, and in patients with atherosclerotic disease, you can get aneurysms big enough to project from the heart. In children with Kawasaki syndrome, you can get aneurysms big enough to project from the heart. In this case, it was a right coronary to superior vena cava fistula, giving this big conglomeration of vessels which is projecting from the heart. There is no specific appearance to this, but when you see a bump on the heart that is peculiar, it could be metastatic disease, of course, but if you have no evidence for this, at least think of the possibility of a coronary artery malformation. Now, one of the problems we have with MR, especially spin echo MR, is sometimes, especially in a patient who has had a myocardial infarction, it's important to distinguish, does the patient have a thrombus in the left ventricle? If they have a thrombus in the left ventricle, obviously it can embolize. And on spin echo images, now this patient did not have an infarction, it's a hypertrophic cardiomyopathy, but you see these signals alongside the wall. And on spin echo images, normally the blood is black because it's flowing rapidly, and the blood that has been stimulated by the RF pulse is somewhere down at the toes by the time you sample and get your image. However, if the blood is flowing slowly, and on cardiac gated images, you frequently will see signal from the blood during diastole, and then the problem comes up, are we looking at clot or are we looking at slow flowing blood? In some cases, we usually do our studies with 2 echoes. On the second echo, slow flowing blood will have an increased signal, whereas clot will have a decreased signal. It does not hold in every case. And lately we've gone more and more to doing gradient echo movies, since flowing blood will look white, whereas myocardial tissue, this is a hypertroph also with an aneurysm at the apex of the heart, will look more gray. So if we can see flowing blood like this, I think we can reasonably exclude the presence of thrombus. This is a not that rare condition. This is a idiopathic hypereosinophilic syndrome. It's a group of different lesions that actually wind up giving a restrictive cardiomyopathy. But the thing of importance to us is that these patients do get plaques on their endocardium, usually in the left ventricle, usually right in front of the mitral valve. These are not neoplasm. They look like a mass. They are fibrous plaques, and sometimes they have a mural thrombus sitting on them. This is first and second echo images of such a patient. The patients usually die of their heart disease within 6 to 8 months, 6 to 12 months at a time the original diagnosis is made. But this is not a tumor. And lastly, I want to show this patient. This was a lady who had a coronary bypass graft done a year ago, had a good result, her angina was gone, and comes back to the hospital now in terrible, terrible left heart failure. And the cardiologist wanted to recatheterize her, and she refused. She'd had enough. And they did an echocardiogram, and they thought they saw some compression of the left atrium, and sent the patient to us for MR. And I remember when I did this study, it's the first cut I got on the transverse cut, and I saw you have two, in the region of the aorta, there are 2 big areas. They're black, therefore this is flowing blood. And the differential diagnosis here, I figured this was the aorta, could this be an aneurysm of the left sinus of Valsalva, which is posterior, conceivably, or could it be a false aneurysm? But it's black, so there is flowing blood. Here you can see the marked compression of the left atrium. In the frontal view, here is the mass compressing both right atrium and left atrium. But if you look up here, in the aorta, it looks like there's a flap of tissue. See the same thing over here. And here it is in the frontal coronal view. You see this flap. And now this is a dissecting aneurysm. Here is the true lumen. Here is a dissected intima. Here is a false lumen of the aorta. She had a dissecting aneurysm. This is not that rare in patients who have had coronary. It's rare, but it's one of the more common complications, serious complications, in patients who have had coronary bypass surgery, getting a dissection beginning at the point where the vein is plugged into the aorta. You also see this in patients who have had aortic valves put in because of the incision in the wall of the aorta. And this false aneurysm had ruptured, rather dissecting aneurysm had ruptured, giving her a false aneurysm which was compressing the heart. In summary, in terms of cardiac tumors, number one, MR is not going to replace echocardiography. Echocardiography is too easy to do, it's portable, and it's not as expensive. On the other hand, a great number of our patients now come from the echocardiographers because in the past, when they saw things they didn't understand, now we can work it out for them. In many cases, they can miss tumors, and often they pick up normal anatomic structures that are misinterpreted as tumors. The MR is by far and away the best technique for detecting cardiac tumors. We can localize them rather accurately, whether they're in the wall or in the lumen or within the pericardium. We can evaluate their mobility by using MR movies, and we can tell something about their hemodynamic effects. We can watch them as they flop back and forth or what they obstruct. Unfortunately, where MR falls short, and there is no other technique at present that can do this, we cannot distinguish between benign and malignant. I don't think we can do this anywhere in the body except with very specific lesions, nor can we predictably delimit the extent of the tumor and say whether it is truly resectable or not. Thank you.